everyone, it's Anthony Chadwick from the Webinar Vet. Very pleased to welcome you to this, our first ever webinar in collaboration with the Royal College of Veterinary Surgeons. We are very fortunate to have Pam Mosedale on the line today. Pam is an RVC graduate and ran a practice in New Mills in Derbyshire until a few years ago when she sold it, and she did that so she could concentrate more on practice standards. She's been the chief inspector until 2 years ago, and in fact was involved with practice standards in the original BSAVA scheme. Pam is also an assessor for SQPs with AMTRA and still manages to spend some time doing some locuming to keep her clinical hand in. And Pam, I'm going to pass over to you. We're looking particularly today just at practicing to core standards. So I will pass over, and unless there's any issues, I will leave you to it, and looking forward to some questions at the end. Thanks, Pam.
Thanks, Anthony. Good evening, everyone. Thanks for coming along to listen to this. This webinar is intended to provide some practical advice on achieving core standards of the RCVS Practice Standards Scheme. In the time available, we will not be able to look at all the standards in detail, but I'm hoping to give you an overview of a core standard. Now, if I can just work out how to change my slides, we'll be all right. Oops, there we go. The core standards are mainly legal requirements such as health and safety, COSH, the veterinary medicines regulations and employment law, which I'm sure most of your practices are already compliant with. There are also some standards concerned with better professional practice. These areas are emphasised more at the GP and hospital levels of the scheme. The Manual of Standards for the Practice Standards Scheme, showing the standards for all levels of the scheme, are available on the RCVS website at www.rcvs.org.uk, Practice Standards, and I would urge everybody to look at that. The different accreditations that can be achieved are shown on this slide. The terminology tiers has now been dropped, no more tiers, and the three main levels are now core standards, general practice and hospital. So there's core level, there's general practice, which is then divided according to species, so you can have general practice small animal, general practice farm animal, general practice equine, emergency services clinic, and then the small animal hospital and equine hospital. If your practice joins the Practice Standards Scheme, all branches of the practice must be accredited, but it can be at different levels. For instance, you could have a practice that had a small animal hospital, an equine GP practice, a farm animal GP practice, and maybe 3 core standard branches. So you may be wondering, why is this relevant to me if my practice is not in the Practice Standards Scheme? You've probably all seen that the Royal College of Veterinary Surgeons launched a new Code of Professional Conduct in April this year. You've probably all received a hard copy of this short document through the post. There is a much longer explanatory guidance document available on the RCVS website. The code has versions for veterinary surgeons and for registered veterinary nurses. Today we're focusing on one key change. There is an important change in the code. It now states that veterinary surgeons and veterinary nurses must maintain minimum practice standards equivalent to the core standards of the RCVS Practice Standards Scheme. Note it says equivalent to. Nowhere does it say that practices have to join the PSS Practice Standards Scheme, which is a voluntary scheme. But it does mean if your practice is not in the Practice Standards Scheme, it is useful to know what the Practice Standards core standard is to ensure you're fulfilling this requirement. So that is what I'll attempt to do in this presentation. But as I said before, we won't be able to cover all the details, so please also have a good look at the manual online as it affects your practice. So we'll go through this in the order of the sections of the Practice Standards Manual. And the first section of the manual concerns staff. So the vets and nurses in the practice must be registered with the RCVS. Any SQPs must be registered with AMTRA. The practice must provide a written statement of terms of employment for all their employees. There should be job descriptions. The employees should be aware of their job descriptions, and these should be reviewed annually. There should be an equal opportunities and non-discrimination policy. CPD records must be kept for all vets and RVNs, and these should be fulfilling the RCVS minimum CPD requirement, which is 105 hours over 3 years for vets and 45 hours over 3 years for RVNs. There should also be a system of staff induction. There should be a performance review system for clinical staff. This does not have to consist of formal written appraisals. It can be a more informal system, but should be able to be demonstrated. There should be a practice biosecurity policy. This is very important and should cover cleanliness, hygiene, disinfection, infection control measures generally in the practice. And there should be an expectation of professional standards of behaviour and appearance for all staff. The second section of the Practice Standards Manual deals with clinical governance and communication. Clinical governance is a new term for many practices, and the code now requires that veterinary surgeons must ensure that clinical governance forms part of their professional activities. So what is it? What are we talking about? Here is a definition from the NHS. A framework through which organisations are accountable for continually improving the quality of their services and safeguarding high standards of clinical care by creating an environment in which excellence in clinical care will flourish. That's a bit wordy, but basically it's the process of achieving and delivering good clinical care, which is surely what everyone in practice is aiming for. It's not really something new. It's what we've all always been doing, discussing cases, thinking about what we do, and trying to see if we could do any of it better. Okay, so what about some practical ideas? I've put together some examples, but don't be daunted by a long list. Just choose the ideas that are relevant, will work, and be useful in your own practice. This should not be a bureaucratic exercise just to satisfy the college. It should be about making a practical difference to patient care in your own practice. Clinical team meetings are one of the simplest ways of implementing clinical governance and good communication in practice. Most practices do have practice meetings. The key is to hold them regularly. Also, it's important to make sure clinical matters are discussed and not just the usual general administration matters, which can, in all practices, start to dominate the meeting. And the other difficult bit is recording the results of the meeting. So any changes discussed can be followed up at the next meeting. So have your meetings regularly. Try and make sure that all members of the practice try to attend. It's important members of the team make an effort to attend, and it's also very important that all members of the team can input areas for discussion. So make sure you've got a list on the computer or on a board somewhere where people can jot things down when they occur to them to discuss at the next meeting. If geography or working hours make face-to-face meetings difficult, then make use of modern technology. Use email discussion groups, use the intranet, use Skype. All these things can be useful. So, and when you've had the meeting, make sure you follow it up and make any appropriate changes, and then revisit those at future meetings and monitor the changes. These meetings can also be a very useful arena to bring back information learned at CPD meetings and pass it on to the whole team. In the very unfortunate event of things going wrong, the dreaded anaesthetic death, for instance, then it's good practice to hold critical or significant event meetings as soon as possible after the event. A significant event might be, as I said, an anaesthetic death, an unexpected medical or surgical complication, a serious complaint, an accident. The key goal of these no-blame meetings is not to assign blame, but to identify any changes in procedures which may help to prevent a repetition. Record all the details of the meeting. Consider what, if anything, could have been done to avoid this incident. Sometimes there isn't anything, but see if there is anything, and if there is, as a result of this, make the changes. and see what changes can be made as a result. So, for instance, you may need to modify your anaesthetic protocol as a result of an anaesthetic death. Practice protocols or guidelines for clinical conditions can be very useful, especially if all the vets have had input to drawing up the guidelines. The discussions around drawing them up can provide an opportunity to examine the evidence base for procedures. Keeping a manual of procedures and other useful information is very helpful when the practice take on new staff or locums. So build up a manual and regularly update it and make it available to new staff. It's also useful to run clinical or journal clubs, either live or online, to discuss cases and clinical papers. Obviously, animal safety is the most important consideration. One way to monitor this is clinical audit, which is the collecting and recording of clinical information with the aim of monitoring the quality of care. There's no obligation to carry out clinical audit. We're not asking to do it for practice standards, but if practices want to start the process, a very useful website is the Vet Audit website, which describes an example audit on the post-operative complication rates for routine neutering procedures. It explains it very clearly, and this would be a very good start for any practices wishing to embark on clinical audit. Another part of animal safety is to make sure that staff are aware that referral is always an option for a client. Can't stress enough practice communication. Most of the complaints that the college receives are to do with communication. Make sure there's good communication with clients from newsletters or websites. Monitor and take notice of client feedback. Staff badges or photos in the waiting room will make sure clients know who they were dealing with. Make sure you have a complaints procedure. Record all the complaints and record the compliments too, or it can get a bit depressing recording only complaints. Make sure you have a clinical case handover system to ensure continuity of care. Some of you may be listening to this and worried that if your practice has not yet embraced clinical governance. So what can you as an individual do to make sure you're fulfilling your responsibilities? Well, you can keep up to date with your CPD. You can think about how well or not your cases have gone and learn from any mistakes. You can consult colleagues who may be more experienced or more qualified and ask them for advice when you're not sure about anything. You can look at the evidence base for procedures that you do. You can analyse how you communicate with other members of the team. You can see how you communicate with clients and think about how things went. So think about all those things, and as a result of those, make appropriate changes to your practice. Right, section 3 of the Practice Standards Manual is about out-of-hours patient care. 24-hour emergency cover must be provided for the care of those species treated by the practice during normal working hours. This includes visits where necessary. Section 4 is premises and outpatient facilities. I've just got something come up on my screen that shouldn't be there. Oh, it's all right, it's gone. Anthony, I've got a box on my screen that so I can't see my slides. Hello, you there, Anthony?
Hi, Pam. We can't see anything. We can just see your slides.
Sorry, Pam, I just had to unmute myself there.
No, you're okay.
Yeah,
I've got
suspect it's the box. It's the little orange arrow. You have to just click it.
Okay, lovely. Thank you very much. Sorry about that, everybody.
Okay, no worries,
yes,
no
that's
worries.
lovely. Thank you.
Fine.
Thank you. Right, so sorry about that. We go back to premises and outpatient facilities. So premises need to be clean and tidy. They need to be accessible, well maintained, and have adequate waiting room. The consulting room should have a cleanable floor and table. It should have washing facilities in the vicinity. There should be basic diagnostic equipment, like for instance stethoscope, oroscope, ophthalmoscope. There should be adequate ventilation and lighting, and there should be scales or a means of estimating weights, such as charts or tapes for horses. It is important to have accurate clinical records. This should include the ability to give itemised invoices to clients and to be able to generate fee estimates. You should be able to discuss changes in charges. For instance, when animals are hospitalised for long periods, you should be able to update and communicate with the clients to let them know, especially if it's gone over the estimate. Should have a clinical history, and there should be a good system for filing and locating the records. Records do not have to be computerized as long as they can be easily located. For the large animal practices, equine and farm, the vehicles that are used should be clean and well maintained. It's important to have segregation of the clean and dirty items. There should be equipment to allow basic procedures to be performed at the client's premises, and there should be a means of disinfection after each visit. And medicines should be stored properly, which we will get onto shortly. Section 5 deals with inpatient facilities. If animals are admitted to the premises, there should be informed consent for all procedures. Kennels, or indeed stables, should be secure and have bedding and feeding equipment. There must be a written policy on overnight care in the practice, and owners should be informed of what the arrangements are. There should be isolation facilities, but these do not need to be separate. You can have separate isolation or you can have cross-isolation where cats can be isolated in dog wards and vice versa if appropriate. There should be an SOP, a standard operating procedure, that makes it clear how and where isolation takes place and has clear instructions for barrier nursing, infection control, disposal of waste and zoonoses. Where applicable, if the practice has an operating theatre, it needs to be uncluttered with easily cleanable surfaces and a good source of illumination. There should be equipment for administering oxygen and resuscitation appropriate to the species treated. Anaesthetic equipment must be serviced according to manufacturer's recommendation. There should be scavenging, active or passive. And anaesthetic pollution should be monitored by staff wearing monitoring badges that detect levels of anaesthetic gas in the atmosphere. Remember, it's important to do this in the recovery area as well as in the theatre. If the practice has an active scavenging system, then this needs to be serviced annually, and this is an alternative to using the monitoring badges. There must be adequate facilities for the sterilisation of instruments using a recognised method. So for most practices that would be an autoclave. And most autoclaves need a written scheme of examination under the pressure systems safety regulations. There should also be a range of instruments and suture material. For dentistry, you need to have a selection of dental instruments suitable for the species, scalers, elevators, luxators. Don't need fancy kit like ultrasonic scalers or drills. But staff should be trained in the care of the dental instruments, in how to look after them, sharpen them if necessary, keep them in good condition. There should be PPE, personal protective equipment, which should include gloves, goggles, masks, etc. The next section of Practice Standards Scheme covers diagnostic equipment and facilities. In core standards, this mostly applies to X-ray equipment. If the practice have X-ray facilities, they must be able to produce diagnostic quality radiographs, obviously, of the species treated, otherwise not much point in having them. But they also must comply with the relevant regulations. So the practice needs to appoint an RPA, that is a radiation protection advisor. The RPA will give a report to the practice on what needs to be done for radiation safety, and the practice needs to comply with any recommendations from their report. Also need to appoint an RPS, that's a radiation protection supervisor from within the practice, who supervises radiography and safety within the practice. Need to have written local rules which should be displayed, and need to have a clearly demarcated controlled area with suitable warning signs, etc. There should be personal dose monitoring. The X-ray machine needs to be serviced annually. Personal protective equipment should be available and should be stored correctly, so aprons, gloves. Important with aprons to have them stored so that they don't crease and crack the lead. There should be grids and cassettes. Everything, the beam should be correctly collimated. If the practice is using chemical processing, the area used must be well ventilated and the chemicals must be disposed of correctly. This is becoming less of a problem these days with the increased use of digital radiography. Section 7 covers laboratory and post-mortem facilities. If the practice has lab equipment, it should be kept in a clean, tidy, designated laboratory area. In this area, there should be facilities for, or in or adjacent to the area, there should be facilities for washing hands, a fridge for samples, and waste disposal facilities. Staff should be trained. Staff working in the lab should be trained on handling lab specimens and the risks of lab work. There should be an SOP, a standard operating procedure, for the post and packaging of samples to external laboratories. Again, this is if applicable, if the practice has a lab. The next section of the Practice Standards Manual concerns medicines. This is very relevant to all practices, as the VMD, Inspections and Investigation Team, will visit those practices not in Practice Standards Scheme to check that they comply with the veterinary medicines regulations. Medicines must be stored in a clean, tidy location, which is separate from areas for human food and drink, and separate from toilets and washing facilities. These areas should not be accessible to the public. Medicines should be stored according to the manufacturer's SPC. The SPC is a summary of product characteristics. This can be found for every veterinary licensed drug on the VMD website. It's nice and easy to find. Front page of the website, right-hand side, click on Product Information Database, and every veterinary licensed drug is there. And you can click on the drug and get its summary of product characteristics. If you look at these, you can then see whether there are any special storage conditions. Wherever temperature-sensitive medicines are stored, there should be proper monitoring and recording of minimum and maximum temperatures. This can be done using various different thermometers, from basic greenhouse thermometers through to the little electronic thermometers, as in the lower picture on the screen. These have a probe which is in the fridge, or sometimes they can be wireless, and they record the temperature in the room and also the temperature in the fridge, which is very handy if the fridge is in the dispensary, as you can monitor both lots of temperatures from the same piece of kit. They're quite cheap and easy to use, and they show minimum and maximum temperatures. You can also use data loggers, as in the top picture. If you use data loggers, they need to have an alarm, so you can see at a glance if they've gone out of the range. The range for fridge medicines is between 2 and 8 degrees. The range for most medicines kept in the dispensary should be kept under 25 degrees. The reason for using minimum and maximum thermometers for the fridge is to make sure they have not gone out of that range. It's not so important to get the ambient temperature at that minute that you open the fridge door. It's more important to know that the drugs in there have not gone out of the range 2 to 8 during the previous 24 hours. And you can tell this from a maximum minimum thermometer. Also, if you look at the SPC, many medicines stipulate that once broached, the contents must must be used within a specific time period, usually 28 days. So if you look on the SPC, or if you get your glasses out and look at the tiny print on the bottle, unfortunately it says on most of these, do not, once broached, use within 28 days. So these products must be labelled with the date of opening and discarded after the specified period has elapsed. No veterinary medicinal product should be on self-service except those that have the legal category AVM GSL. It's important to keep records of everywhere that medicines are stored. This includes branch surgeries and cars. Accurate records should be kept. This is important if you're having deliveries to a main surgery which are then being taken out to branches, maybe large orders which have been spread out to branches. It's important to keep a record of where everything is. All food animal records must include the batch number. Out-of-date medicines must never be supplied or administered, and all medicines must be disposed of according to current regulations. There's very useful advice on waste disposal on the BVA website and the BSAVA website. And any special handling or disposal requirements must be observed. Drug audit is something which I think worried a lot of people when it came in the veterinary medicines regulations. And the practice must have the ability to carry out a drug audit. They must have an efficient stock control and stock rotation system, but also have the ability to carry out a drug audit. In order to carry out a drug audit, the practice must record all the drugs that are purchased. This is quite easy from wholesaler invoices and delivery notes. Practice must also record all drugs used and sold in the practice. This is not too difficult if they're computerized and have a practice manager software system that you can type in what 2 dates and see which drugs you've used between those dates. If you're not computerized and it's a manual system, it can be a bit tedious to go through to find out which drugs were sold, but you need to keep a record. You need to carry out a stock take at least annually, and most practices do this anyway for accounting purposes. And you need to continuously audit Schedule 2 controlled drugs, which we will come on to in a moment. In addition to that, the practice should record any out-of-date and damaged drugs which are disposed of and account for discrepancies. Obviously, there will be discrepancies with drugs that might be used within the practice and not charged out. Therefore, you need to keep a record of these. If the practice uses controlled drugs and keeps them in stock, they must be stored and recorded according to current legislation. So, Schedule 2 controlled drugs, as for example methadone, pethidine, morphine, fentanyl, should be recorded in the controlled drug register and stored in a locked controlled drug cupboard, except for quinylbarbitone, Somulose, which has no requirement to be kept locked up. Schedule 3 drugs, buprenorphine and barbiturates, for example, should be kept in a locked, secure cabinet, but do not need to be recorded in the controlled drug register. There is no legal requirement to record ketamine or to keep it in a locked cupboard, as it is a Schedule 4 drug, but the Royal College advises in the Code of Professional Conduct that it is kept in a locked cupboard and recorded. Controlled drugs must be kept in a secure, lockable, immovable receptacle. And access should be restricted to a veterinary surgeon or a person authorised by them. The person authorised may be a veterinary nurse. The key should not be left lying around in the practice or left in the door of the controlled drug cupboard, as in this picture, which is a common finding on both PSS and VMD inspections. And that is on the day of the inspection, when practice know the inspector's coming round, still find the key in the door, so it's good practice to make sure the cupboard is locked up. The controlled drug register, a controlled drug register of Schedule 2 controlled drugs must be kept in accordance with the Misuse of Drugs Act. If you supply controlled drugs against another veterinary surgeon's prescription, The name of the person collecting the drugs must be noted, also be noted in the register. The controlled drug register must be a bound book with a separate section for each drug, each strength of the drug. Entries should be in chronological order with no alterations. So the book in this picture, the top picture, would not be suitable as it's a loose leaf book. A page could easily be torn out without any trace and the equivalent amount of drug removed. Entries, as we say, should be in chronological order with no alterations. If you do make a mistake, just cross through it and initial it, no tip X or scribbling out. If the controlled drug register is computerized, a safeguard should be built into the software to ensure the author of each entry is identifiable and that entries cannot be altered. For whatever the register, it's really important that someone checks regularly the stock in the cupboard and the balance in the register agree. This is the continuous audit of controlled drugs referred to under drug audit. And so it needs to have a system that once a week or more often, if using controlled drugs quite a lot, someone has a look, is responsible for looking, one of the vets or the head nurse is responsible for checking that if it says there are 13 vials of morphine or 6 fentanyl patches in the cupboard, if it says that they are in the register, then that is the number that are in the cupboard. Out-of-date controlled drugs must be destroyed or denatured in the presence of either a PSS or VMD inspector or an independent vet, so that's not somebody who works for the practice, not a locum, not one of the members of staff, husband or wife, a completely independent vet, or a person authorised by the Home Office, or a drug liaison officer from the police. I don't know if you've seen these controlled drug denaturing kits. They're nice and easy to use. You just put the drugs in. It's like a powder in there. You put the drugs in, fill it up with water, shake it, and it sets solid, rendering the drugs irretrievable. That's the way to dispose of your out-of-date controlled drugs. And if you're having an inspection, it's a good chance to get those sorted out. Prescribing and dispensing. Veterinary medicinal products should be prescribed and supplied according to current guidelines. Before prescribing POMV drugs, a clinical assessment must have taken place, and the animal must be under the veterinary surgeon's care. For repeat prescribing, each individual transaction must be authorised by a vet. This can be done either by the vet marking a client's records in advance, so put a note on the records, the vet puts a note on the records saying a certain drug, Metacam, Rimadyl, can be supplied for 3 months, providing the animal's doing fine. Or by the request for a repeat medication being recorded by a receptionist or nurse who answers the phone, being recorded in a book or on the list on the computer, and then the veterinary surgeon comes along and okays it, but need to show that it has been okayed by a vet. The vet must be satisfied that the person handing over the drugs to the client is competent to do so. That's easy to say, but sometimes difficult to assess. How can you ensure your staff are competent to hand over the drugs? This is by making sure you have SOPs, standard operating procedures again, for dispensing, and ensuring that staff are well trained in their use. There's some really good examples of dispensary SOPs on the BSAVA Guide to the Use of Veterinary Medicines, which is on the BSAVA website and available to all, not just members. BVA also have a very useful good practice guide on veterinary medicines, so use these to make sure you're training your staff. Staff also must advise on the safe administration and any warnings for use, and they must try to ensure that the user is competent to use it and knows exactly what they're doing with it. If you have an SQP in the practice, a suitably qualified person who's supplying NFA VPS or POM VPS drugs, if you have an SQP, they must be on the current AMTRA register, and their qualifications must be appropriate for the product range they prescribe or supply. All containers must be legibly and indelibly labelled. For POMV medicines, the label should contain the name and address of the animal owner, the name and address of the veterinary practice, the date of supply, the words "keep out of the reach of children," the words "for animal treatment only," the words "for external use" if it's a topical preparation, and the name and quantity of the product, its strength, and directions for use. Don't have to be computer labels, handwritten labels are acceptable, as long as they're legible. For medicines supplied under the cascade, there's some extra information. There's all the information we mentioned already. We also need to have the name or initials of the actual veterinary surgeon who prescribed the drug and the expiry date if that's not on the packaging. So in this example label, it's sulfasalazine, which are loose tablets. So the expiry date would not be on the bottle. So we've put the expiry date on, and then we've got my initials as the initials of the vet prescribing the drug. Vets must prescribe according to the cascade. If any unlicensed medicines are used, informed consent should be obtained from owners, preferably in writing. Suitable off-license consent forms are available on the VDS website. There are two forms of these the consent forms. There's a lifetime form, which is suitable to be used for exotics, because there's not many drugs that are licensed for bearded water dragon or something like that. For cats and dogs, consent is needed per drug used. So if you get, as in the top picture, there's a whole lot of human drugs there. If a dog's prescribed Destillate, owners have to sign a consent form. But then if a few weeks later they have Antepsin, then you need to do another form for that. The owner should also be supplied with any necessary warnings on the use of the product and the disposal of the product. And as I just said before, there are additional labelling requirements. Keep records of all products imported using special import certificates. And for food animals, keep records for 5 years of any cascade products, which obviously must include batch numbers. There should be a notice in the waiting room informing clients that they can request a prescription. Suitable text for this is in the PSS manual. And there should be prescription forms or a code of practice for prescription writing available to vets. Adverse events must be reported promptly to the VMD under the Suspected Adverse Reaction Reporting Scheme, SARS. There should be a protocol for how and when to use the SARS forms. They're at the back of the datasheet compendium, but they're also online and easy to find at the VMD website. Should keep a record of any adverse events that you've reported. And don't forget to report lack of efficacy. This is particularly important for antibiotics and for wormers because of potential resistance problems. Right, we're nearly at the end of the manual now. The last section is health and safety. I don't intend to go into this in great detail, but it will just give you a brief outline of what's covered in this section. So the practice must have a health and safety policy, and if 5 or more people are employed, this policy must be in writing. Practice should carry out risk assessments, task assessments. Staff should have access to all recent updates to the policy. Staff should sign the policy and any reviews. A safety officer should be appointed. It's important to consult with staff about health and safety, and the practice meetings, which we talked about earlier under clinical governance, are a good chance to air any concerns about health and safety. I would heartily recommend that you go on the HSE website, www.hse.gov.uk, which has extensive information on health and safety and makes it very easy to see how to do these things. There are companies that will do health and safety assessments for you, but it's important that these are personalised to the practice. The kind of risk assessments that need doing, there's a full list in the manual, but the sort of areas that should be covered are cleanliness and tidiness, slips, trips and falls, as in the photograph, vehicles and driving for work, disinfection, manual handling, work-related stress, staff security, lone working, zoonoses, waste disposal. I say there's lots more in the manual, so have a look through them and make sure that you've assessed the risks of all those. The control of substances hazardous to health, COSH, requires that the risks of exposure to veterinary medicines and hazardous substances be assessed. The hazardous substances can be classified as low, medium, or high risk. For high risk substances, you need to do a detailed risk assessment. The sort of high risk substances we're talking about in practices are oil-based vaccines in large and small animal practice, cytotoxic drugs, glutaldehyde disinfectants, hormones, tylemycin or Micotil in large animal practices, some of the sarcoid creams in equine practices. Measures to control exposure to these substances must be identified to all staff. Now, we used to have to keep all the data sheets for safety data sheets for all these products. It's not really necessary to do that now. They can be accessed online. Veterinary licensed drugs, as I said before, from the good old VMD website, Product Information Database. Look for the SPCs. Also the NOAA Compendium. Human drugs used in practices can be information can be accessed from the ABPI datasheets, but also from a very good EMC website, Electronic Medicines Compendium, which is at www.medicines.org.uk. So that's fine to have, as long as you have a clear protocol of exactly how those are accessed, that's good. But for high-risk substances, a hard copy of the information should be available as well. So in the event of an accident, this could be taken along to the hospital. Need to appoint a fire officer and do a fire risk assessment of the premises and make sure that fire extinguishers and fire alarms are serviced annually. Need to have an accident book and everybody in the practice needs to know where it is, and it needs to be filled in for accidents. And it needs to be a data protection compliant accident book where the page is torn out so you can't read everybody's details. Need to have a first aid kit, and yes, I know that veterinary practices have loads and loads of bandages, but you still need a first aid kit. A person also needs to be appointed to take charge should someone fall ill or be injured, and to restock the first aid box as required. That's an appointed person. The electrical installation of the building needs to be checked by a competent person. That is the wiring, basically, and that competent person will tell you how often that needs to be checked. It's often every 5 years. Portable electrical appliances should be visually inspected at least annually. That's looking at them to check the plug and the cable, check everything's okay and not frayed or cracked. There should be a combined inspection and test at least every 2 years. That's PAT testing. And there should be regular maintenance of any gas appliances. Waste, hazardous waste, called special waste in Scotland, and non-hazardous waste, non-special waste, should be segregated. They should be stored correctly. Any waste contractor that you use should be registered with the Environment Agency, or SEPA, in Scotland. And the practice should be registered with the Environment Agency if you produce more than 500 kilograms of hazardous waste per annum. And again, I would recommend the BVA Good Practice Guide to Handling Veterinary Waste, which will give you a lot of information on this, and also speak to your own waste contractors. Hopefully this presentation has shown you that reaching core standards is achievable. It's mainly common sense, and in fact it's probably what most of you are already doing, but considered in a more structured way, which means it's easier to ensure you achieve the standards and that you maintain those standards afterwards. So, thank you very much for your time, and if you've got any questions, please let me know.
Thank you, Pam, so much. That was great. That was such a current, comprehensive and concise run through the Practice Standards Scheme, which, you know, as you mentioned, is not obligatory, but every practice has to be able to say that it is at the core standards. So I think it's such an important issue, and I think you've gone through it so well. And hopefully helped the people who've been watching it. If anybody has any questions, I know Pam is happy to answer them. So there is a box at the bottom of your little box at the side of the right with the orange arrow, which says questions. So if anybody wants to type in questions, those of you who are first on to webinars, I know a lot of you are regular attendees at our webinars, so you know how that works. But if you can just look for the questions box and you can type a question in, and then just send it to us, and I will try and get through as many practical questions as possible. If you have questions more about the policy and why practice standards is in place, feel free to put them in, but I will be passing them over to the Royal College so they can answer them in more detail. But I know, Pam, I was very fortunate. Harvey Locke came to my practice a couple of years ago to do the audit, and I thought it was a great way of just checking that the practice is running as it should be, that we do have the right things in place. And I found it a very, very helpful exercise. I was going for Tier 2 at the time, but it really was a very good way of just checking that the standard of the practice was where you wanted it to be. So do you find that most people approach it in that way, that you go out and, well, when you were visiting?
Yes, I do actually. I think the sort of feedback that we tend to get is that practices will often say, oh, well, we thought this would be a lot of paperwork, and it was a certain amount of paperwork, but now we feel that we've got the systems in place, and we feel more confident that we have got the systems in place, and that now it'll be easier to keep up with it, and we know that we're actually complying with all the legal requirements, and it gives us peace of mind.
Very much, yeah. And I think the legal requirements, none of us want to be caught out with, not fulfilling health and safety or whatever, and then being in trouble because we're not looking after our staff properly. So I think it's been a great step forward, BSAVA, and then of course the Royal College. So thank you for all your hard work in making sure that we're all doing what we should be doing.
Oh, I enjoyed it. I like going and looking around lots of practices. I find it very, very, very interesting. And the other thing that in practice standards now is that we don't just look at paperwork. Inspectors do talk to staff and find out how systems actually work. Not just look at a piece of paper to say what practices do. We actually see how it works on the ground as well.
Right. Okay. Great. We seem to have some questions coming
through.
Oh,
right.
So,
okay, fire away.
Hopefully we can. You're not going out anywhere, are you, Pam? I think this is good. But it's good. It shows that there's a lot of interest there. Right. Okay. We've got here. This is a question from Helen. Are there any form of ideal or outlined CD record books available, or are practices just expected to create their own based on the rules?
That's a very good question, thank you. There are, on the picture further back, I showed a picture of a book that's produced by National Pharmaceutical Society, I think it is, which although it looks like a folder, has actually bound sections within it, but that's not ideal because it's not meant for veterinary practice. There isn't an ideal register, I have to say, that you can just buy off the shelf. Any sort of book is okay as long as it's a bound book. But interestingly, only last week the VMD have actually put a sample controlled drug register on their website. So, I'm happy in your blog afterwards to put the link to that so that people can have a look at that, which shows how you should set up your controlled drug register.
Yeah, great. The dispensary and fridge rules seemed to suggest that if an alarm is not in operation, then temperatures all need to be recorded daily. Is this correct?
Oops, funny noise. They need to be looked at daily, definitely. If your data logger has an alarm, and you can just glance at it and make sure, because you can download your data logger just once a week, but obviously it's no good finding out that your fridge has been out of range for the last 6 days. So you need to have an alarm to see, or if there is no alarm, then someone needs to look at, you need to have a thermometer as well, and someone needs to look at that. They need to be looked at daily and recorded at least weekly.
Great, okay. So yeah, that just kind of makes sure that we're not in a situation where if you've been out of the target for a week, then of course
That's
a lot
right.
of those drugs theoretically, well, actually do need to be thrown away, presumably.
Yeah, and the thing to do if that does happen is to actually contact the manufacturer, because it's a combination not only of how far they've been out of temperature range, but how long they've been out of temperature range for. So if you've got, you know, a fridge with a whole load of vaccines in and something goes wrong, then it's important. Then the advice would be to contact the manufacturer before you throw them away and just check exactly what's going on. While we're on that subject, one thing I forgot to say actually was it's fine recording these temperatures, but it's no good doing it if we don't do anything about it. It's no good having a nice lovely chart with everything filled in and the fridge running at, you know, 10, 12 degrees. So it's important, if temperatures are going out of range, to adjust the fridge, and obviously if it's a continuing problem, to get a new fridge or whatever. You know, so that's really important. It's not a bureaucratic exercise, it's to be absolutely useful. And another little tip that one of the VMD inspectors told me was that with the ones where you put the probe into the fridge, sometimes it can be very, very sensitive when you're just opening the door, and you can actually put the probe into a little bottle with either with water in or not inside the fridge, so that you don't get those fluctuations from just opening the door to put the vaccines in or to take the vaccines out.
That's a useful useful tip for everyone. Just go over that again. So you need to...
Normally, with the little electronic thermometers, where you put a probe into the fridge and they stand on the top, as in the picture that I showed you, if that, I mean, obviously the probe needs to be in the fridge, not in the door, but even with it in the fridge, just opening the door for a few minutes to put your vaccines in and out, or to load, for large animal practices, to load the order with a whole lot of vaccine, can cause a fluctuation. So it can look like your temperature's gone up, but it's only been for a few minutes. So you can use what's called a thermal break to stop that happening, and you can purchase a thermal break online, or you can just put the little probe into a medicine bottle with just a little spot of water in the bottom and put that in the fridge in amongst the vaccines, and then you get the temperature of the vaccines themselves rather than just the fluctuations of opening the door briefly.
Right, okay, that's useful. Mike is asking a question: what would you do with half a vial of morphine? You've used half on the dog, you've got half left. How do you deal with that?
That's another difficult question that comes up quite a lot. I mean, basically, if you've not got any other patients that you're going to use it on immediately, then that has to go to waste. And this sample register that's on the VMD website shows, you know, so you would give 0.8 to the animal and 0.2 to waste. And as far as the waste goes, you need to render it irretrievable. So you can put it into one of those pots that I showed you, a denaturing pot, which you keep in the controlled drug cupboard, or indeed into something like cat litter in a pot in the controlled drug cupboard. That doesn't need to be witnessed. The witnessing is when you've got large quantities of or any quantities of out-of-date drugs. The little ends of the vials don't have to be witnessed, but they do have to be rendered irretrievable.
So you put them into cat litter, a little pot, and then do you keep hold of those pots?
Yes, and you just keep putting it in, and then eventually throw that into your pharmaceutical waste. But it's somebody who can't get it out again from there and use it for any purpose.
So you've got the 0.2 mils left of the morphine, you pour it into a little pot with some cat litter in.
Draw it out. I mean, you can let it evaporate. The other option is some practices leave the vial in the bottom of the controlled drug cupboard, but and let it actually evaporate. But the problem with that is that somebody could come along and draw it out. So you're better to actually draw it out and put it into a denaturing pot, or just some cat litter in a pot in the bottom of your controlled drug cupboard. Or if it is just tiny, if it is tiny amounts, you can put the vial into hazardous waste. But it's better to draw it out and put it into, make sure it's irretrievable. That's the important thing.
If the next day you've got another vial with 0.3 in, can you put that in the same cat litter box?
Yes, absolutely. You can put it all together, yes.
because obviously these vials can be a health and safety risk in the
Absolutely,
dangerous
that's
drugs
right.
cupboard, so they've got to be thrown away,
Yes,
haven't they, really?
definitely. I think that's much better than just leaving them. But I say some practices do that. But the main thing is not to have them just left around where they could be, where the drug could be drawn out and used.
Yeah.
I mean, I think we're all you know, worry about people breaking in and stealing our controlled drugs, but we've also got to make sure we've got robust systems in place in the practice.
Yeah, sorry. That was me just knocking my mic. Apologies.
It's all right. You've got to make sure we've got you know, robust systems within the practice so that there's no temptation for anybody to be taking drugs within the practice.
Of course. Joe has a question which I think I can answer, but I will just make sure that I've answered this correctly. Are vets now obliged to enter CPD attendance and study online?
No.
I think there was a rule change now, of course, with the new practice standards, with the new RCVS booklet that came out in April, that it is now obligatory for CPD rather than one.
Yeah, but I think Joe was asking, is it obligatory to enter it online? No, it isn't. I mean, there is a system that you can record your CPD online. It's a nice new system on the college website.
That's right.
But you don't have to use that. You can use
they'll use the booklets that they send out, the cards. Yeah,
that's right.
Yeah. Great. Okay. Yes, I believe that is very nice. So it is something to look.
It's very good, and it also explains really clearly what you can count as CPD, because when we were talking earlier about clinical governance, we were talking about having the meetings and the protocols and discussing, all that can count as CPD. If that's structured and recorded, that can count as CPD on top of your 10 hours of private study that you can, well, you can count more private study if it's documented, but you can have 10 hours of general reading, but also your clinical governance time can definitely be counted as CPD. So it can fulfill two requirements with one stroke.
Fantastic. I did also speak to the Royal College about webinars, because people were worried, were they able to count a webinar as part of their study, and the Royal College, I think, seem very pleased that webinars are out there. It makes study very easy for you know, young mums with children in the house who perhaps are having difficulty getting out. Perhaps they're not working full time. It's expensive to get all of the CPD that they need. So webinars are allowed as a way of including, you know, that amongst your CPD. And I think tonight's webinar will allow everybody to get an hour of CPD, and we will be setting up a certificate on the page where we will put the recording for this. So for those of you who want to go over some of Pam's talk again, or want colleagues or friends to have a look at the webinar, we will be sending you an email to direct you to the page once the page is up, and that will also have a certificate for you to download.
Great, and yes, webinars are definitely counted as a CPD. Yeah.
We were very pleased. We did a survey recently to some of our members, and some of the members are doing well over 100 hours of CPD, because it's been made that much easier, which is fantastic.
It certainly is.
The more you do, the better you get.
And as you say, for people at home with children, for single-handed practitioners, for, you know, it's just much easier, isn't it, than travelling and long distances.
Absolutely, yeah. Are smaller branch practices, this is a question from Chris, expected to dispose of bottles of antibiotics just 28 days after broaching?
Unfortunately, yes, is the answer to that question. I mean, obviously you can try and be a bit strategic and, you know, take them back to the main surgery if they're getting near to the date. But yeah, if it does state on the SPC or on the bottle that they should be used within 28 days once they're broached, then I'm afraid that applies to everywhere, and it does make you concentrate more on not having as many bottles open within the main practice. But I think he's right, it is a big problem for branch surgeries. Yeah,
I think it can help you just with, you know, as you say, watching out for stock wastage. But I was glad. I wanted you to be the bringer of bad news there, but yeah, we just.
So yeah.
I mean, what I did in my own practice was, you know, if it was a bottle that you didn't think you were going to use very often, then you sold the bottle to the client. So a drug like mescaline, which you use to prevent a pregnancy, then the client bought the bottle rather than the 4 mils that that the dog needed, and that way at least you're not also out of pocket, Chris. So looking at it from a business perspective,
absolutely.
I think that's it's important that you don't lose money out of it.
Absolutely, and also you can start realizing how much you are discarding, and then you obviously have to adjust the price accordingly. Really.
Yeah. Christabel said, "Thank you for a great talk. The only problem, Pam, and you've done very well this first webinar, but you don't hear the thunderous applause at the end of the talk. So I like to always tell you that a few people have enjoyed it. I'm sure there's lots of people, but there you go." Christabel
Thank you very much.
"Thank you for a great talk." She then asks, with your SQP hat on, is the SQP training actually worth it for QVNs, for qualified veterinary nurses?
I think it depends on the practice, doesn't it? I mean, qualified veterinary nurses, RVNs or VNs, can do a shortened course because they get credit for some of the knowledge they already have. Obviously, it just means that they can supply POM VPS, NFA VPS, depending what practice they're working in. But if they're at maybe at branches where there's no vet or whatever, I think it certainly can be worth it. But then they have to remember that that when they're acting as an SQP, they are acting on their own. They have to take responsibility for their own actions.
Yeah.
I think maybe if more drugs change their category into those categories, it could become more worth it. But who knows for the future? It's
useful for a drug like some of the flea products.
Absolutely,
yeah. The vet's out at lunch. A client comes in and says, "I'd like a packet of whatever drug," and you can't do it as a veterinary nurse, but you can as an SQP, can't you, Pam?
That's right, you can. It's mostly as flea and wormers, and it's also large animal, similar anthelmintics, etc.
I think a lot of the university-trained nurses now do tend to do SQP as part of their training, so yes, they come out as an SQP.
Some of them do, and I think it's useful because they get a lot of dispensary management training as well.
Yeah.
In the SQP course.
Which again, when you think that the drugs is probably the biggest cost or second to staff that you'll have,
yes,
the more that you can manage that, probably the greater profit for the practice.
Absolutely,
well.
And to have members of staff who are motivated and interested in doing that in the practice is very useful, I think.
Yeah. Helen has a question which I think it may be slightly controversial, but I think I'll get away with that asking you. If you say you don't want to answer it, I'll move on to another question.
Okay.
As an assistant, am I, as an assistant, responsible if my practice is not up to core standards?
I think, well, I'm not quite sure is the answer to that question. Yeah, I think that might be a more of a political question. But I mean, obviously, we did touch in the clinical governance area about what you can do yourself to try and make sure you're covering that. And I think that's important because obviously working as a locum, you can sometimes work in practices with different standards. And I think as long as you can try and make sure that you yourself are trying to practice to the best of your ability, that's the best thing that you can do.
Yeah.
But certainly we will get an answer to that question.
Certainly all of these questions, unless anybody emails me to say they really don't want the question to go to the Royal College, the Royal College have then got the opportunity to possibly do a blog on these questions on the website, or they will answer ones that they feel need answering. They will answer them directly to the members, obviously.
Good.
Let me just see. Another question, which I think I can ask you again, Pam.
Go on.
I was surprised that the picture of the waiting room had feed bags, this is a question from Diana, where sick animals will sit, and had a human drink machine where animal noses can reach. Is that, what are your thoughts on that?
It's not unacceptable for core standards. No, but obviously you've got to take into account biosecurity, and it was very kind of the practices who allowed me to take photographs around their practices, and we will have some variations, but obviously it's important to think of biosecurity when you're planning these things.
Okay, great. Livia is saying, do I have to have a thermometer in the dispensary for under 25 degrees, or is it only recommended? How rigid are the regulations about the length of screws, type of wall, fittings, thickness of metal for the controlled drugs cupboards?
Right. Thermometer in the dispensary, yes, you do need to, because obviously otherwise the temperature could be going over 25 degrees, so you do need to monitor that.
Yeah.
And you know, and think about things like if there's a window and the sun's streaming into the dispensary and you need blinds on it, or you know, you need a fan, or you need, I mean, the worst scenario, aircon or whatever. So yes is the answer to that question. What was the second part about the controlled drug cupboard, was it? Can you just repeat that bit, please, Anthony?
Yeah, just really, I think, wanted to know what size do the screws have to be, type of wall, fittings, thickness of metal for the controlled drug cupboard. I think, you know, how easy, you know, obviously if it's screwed to the wall, it's fairly immovable. If it's screwed from inside, isn't it?
It needs to be screwed to the wall. It needs to be a proper lockable cupboard that actually has a lock and a key, and not something with like a little lever lock. I mean, there are regulations for the human versions of these controlled drug cupboards, and we can certainly put a reference to those on the blog. And there are cupboards that are sold by some of the veterinary suppliers that are sold as controlled drug cupboards. But the most important thing is that they're immovable, so they're attached to the fabric of the building, so somebody cannot pick up the cupboard and take it out with them. You know, and that they're a good, solid cupboard with a proper lock, and that there's no notice on the outside of them saying, I mean, you know, even though people don't deliberately put a notice on saying controlled drug cupboard, people often put something like morphine dose on the outside of the cupboard or things like that. So try not to make it obvious that this is the controlled drug cupboard. And it also wants to be in a room that the public can't access.
Barbara's just making a statement here. Some of the wholesalers will supply a handy controlled drug book with cost safety data sheets in an easily accessible form.
Good, that's great.
So for people to have a little look at that.
Yeah.
Is the 28 days rule in tablets of stone? Jock? Yes, I think it is, Jock. Unfortunately,
I think it is. I think you need to talk. I think you need to talk to the VMD, Jock, about that. But yeah, it is there, I'm afraid.
Just looking, there are a few questions here that I think we can still answer. I just don't, for everybody listening, I don't want to put Pam on the spot, because I think Pam practically has been an inspector, but isn't necessarily involved in every single decision made at the Royal College on this. And certainly that was, you know, you finished being an inspector 2 years ago, so that's why I'm
no, just earlier this year I finished being
earlier this year, was it that you finished? Right, okay. Right, okay. We've got just a question on Somnulose. Doesn't need to be locked up either in storage or in cars. That's from Natalie. Is that correct?
Technically, yes. I mean, it is better to have it locked up, but technically the categories it falls into, and I don't know why quinol-barbitone is different than the other Schedule 2s, but although it has to be recorded, it doesn't have to technically be locked up. But I would still recommend that it was.
Jock is a bit concerned about practice cars with regard to medicine storage and temperatures and so on. What's the...
Yeah, Jock is right to be concerned about that. It is a big problem. Basically, it's very difficult to store, as we all know, to store drugs in a car and to not have them going over 25 degrees in the summer, or indeed freezing in the winter. So as far as vaccines are concerned, that's okay. You can have the little plug-in fridges, or you can take them out in a cool box. So it's not really a problem for the fridge items, it's more a problem for the rest of the items. Yeah. And as far as that's concerned, I would say to practices, monitor. I mean, they should be monitoring. They should have a maximum thermometer in the boot, in amongst the drugs that are being stored. You need to monitor it, and then when you find out there is a problem, you need to try and think what you can do. I mean, obviously, keep the minimum quantities in the car is one of them, but that's also not terribly practical. Things like boot covers, so that the sun isn't shining into the car.
Shade.
Yeah, but even with parking in the shade and aircon, cars are still going to get very hot. And also insulated boxes, like the cool boxes that you would take, on a picnic, can be very good for keeping. Not fridge items, ordinary, injectables can be kept in those. And within a practice, you usually find that some of the vets have different systems. Some of them will just keep them in a box, and some of them will keep them in a cool box or in the polystyrene they come in. So check, monitor those and see if there's a difference, and try and find the best system. And there are some of these big cool boxes that you can plug into the car cigarette lighter, and you can set them not at fridge temperatures. You can set them at just below 25 in the summer, but the only trouble with that is they do tend, on a practical point of view, they do tend to drain the battery a bit, I'm afraid, of the car. But those are the sort of things you need to be thinking of.
And perhaps overnight, bring drugs.
Definitely overnight, or if you're not on call, take them into the practice. Do not have them.
Especially if it's in the winter, they could, I suppose, freeze as well. Couldn't
Absolutely, that's right.
Yeah. Louise said, excellent initiative. Nice icebreaker webinar to reach everybody. I hope to see more of these. Too much to cover just in one. And I think we are planning another webinar for tier 2 and tier 3, aren't we?
I think we are, yes, for general practice level. We're not supposed to use tiers anymore, Anthony.
Oh, I'm sorry. I'm out of date. I sold my practice last year, so I passed the tier 2.
Don't worry. Yeah, no, tier 2 is what was tier 2 is now general practice. So yes, I think one. And the trouble is, it's such a huge subject, and especially when you start getting into, equine and farm animal and hospital standards and emergency service standards, it's such a massive subject. But the idea of this one, I think, was just to say this is the core standards, which aren't terribly difficult to achieve, and to reassure people really that practicing to the equivalent of core standard is what we all should be doing anyway. It is the basic legal and minimum to keep yourself safe and secure. So I think, but it is a big subject, and I'm sorry, I hope I haven't rushed through it too much, because it is an awfully big subject. But hopefully on general practice we can go into it in a lot more detail.
Have the tiers, in a sense, is it more of a name change than, or is it a huge change?
No, it is more of a name change. I mean, the standards are when the college took over the standards, they said they would leave them the same initially, but every 5 years the standards are revised, and they're actually revised by the Practice Standards Group, which actually consists of representatives of all the other organisations, and I am the BSAVA representative on that group, and there's representatives from BVA and SPIVs and nursing and VPMA and emergency clinics and all the different organisations. So everybody has an input, and I would really encourage everyone to when someone from your organisation asks for feedback, then do reply to it, because you really can influence how the standards are going to change next time. And it's better to influence it than just to complain about it afterwards when it's happened. So no, it wasn't a big change. There were some changes in the standards. There was change in emphasis, as I say. We do more finding out practically and talking to staff now, but mostly it was a name change, because the tiers were a tiny bit confusing, really. I mean, to the public, I think, because people weren't sure is tier 1 the best or is tier 3 the best.
Yes,
so it's to try and make it a little bit more transparent. We now have core, general practice for the middle tier, and then hospital, which hopefully is a bit more transparent.
Great. No, that's great. Rebecca is just asking, how long are you still okay, Pam, to continue?
I'm fine, thanks, Anthony. I'm just having a drink of water, but I'm fine.
We've still got a lot of people on the line, so they're listening to your every word anyway.
That's fine. Carry on.
Rebecca is asking, how long should copies of SARS forms, unlicensed product consent forms, and SIC, STCs be kept for?
Well, in the veterinary medicines regulations, it says to keep your records for 5 years when it talks about other records. So I would guess go with that, I would have thought.
Yeah. I'm concerned about misuse of meds such as tramadol and diazepam. So how can one keep tabs on this?
Right. I mean,
yeah, that's right. Yeah, sorry, that's the question.
Yeah. Well, those are yes, I mean, diazepam and I mean, tramadol doesn't have to be kept in the controlled drug cupboard, but some practices do that. Obviously, I mean, we're saying what you have to keep in a controlled drug register. You can keep a register of any drug that you want to, and it's a good idea with any kind of drugs of abuse to do that, or potential drugs of abuse to do that. So certainly keeping a record of them, and then this continuous audit, as we described for the controlled drugs, is the important bit. That you don't just have the register, which maybe isn't quite accurate. You actually check the register against the cupboard periodically, and that way you can be sure that that nothing's going astray. The other thing, of course, is to restrict the access to your controlled drug cupboard, not have everybody having a key, and not have it be the safe, not put the money in there as well, as so that lots of people are having to go in.
Yes.
And as I said earlier, the controlled drug cupboard with the key in the door and the door open is quite high on the list. Yeah, I know. On the data
inspector there is probably not a great advertisement.
And the VMD, it's also, the VMD inspectors have told me that that's top of their pops as well. So be really careful with the controlled drug cupboard, I would say. And yes, if you want to keep other things in there, if you should record other things too, that's absolutely fine.
I know at one of the practices I visit, they have a very standard key box that is on a coded number, like a combination lock that you see on some of these attaché cases. And I know my mum, I'm fitting one for my mum's house at the moment, and it's only about £50, so it's not an expensive thing to do. And then obviously you just give the people who need to know the number so that they can go in.
Absolutely.
And I think that works very well.
It does. That works well, especially some practices have only got one key to the controlled drug cupboard, because it may be a cupboard that was an ex-hospital one they've had for a long time, and they've only got one key, and that can be a way around that. Because the ideal, obviously, is for all vets to have a key, but that is a good idea. But if you do that, do make sure that you do change the number frequently. Otherwise, it just becomes as well known what the number is as it is in some practices where the key is hidden.
Yes.
So you've got to change it, and it is good that you can change it regularly.
Yeah, there are, gosh, I'm just saying there are still lots of interesting questions. Can a drugs cupboard have a combination keypad lock rather than a key lock? So that's a slightly different question from Julie.
Yeah, well, it depends. It depends. I mean, if you were having a practice standards inspection, then it would depend on the cupboard, and we'd have to record all the details. With practice standards, basically, anything black and white, the inspector decides on the day, but there are some things that may be a bit more grey area, and for those we record all the details, and all the anything that's not straightforward is looked at by a review group of some of the senior inspectors, so there's consistency. So something like that, we'd want to know the details of that cupboard, because there are some of these ones that are sold as sort of home safes that aren't particularly secure, but there are some that are. So we'd need to know the details, and we'd submit that, and then there'd be a decision made according to the individual circumstances.
Great, okay. Sorry, I misunderstood a question. I'm asking about the tramadol.
Right.
It was, he's just said he's more worried about it misuse by the clients, not within the practice.
Oh, by the clients, yes. Well, the only thing you can do there is prescribe the minimum amount, isn't it?
If you're continually subscribing them, then obviously you've got to ask the question, where's the dog? Is it getting the tablets? And if in doubt, stop doing it, I suppose.
Yeah, absolutely. And with all those sort of things, prescribe the minimum amount for the treatment. Don't be prescribing large amounts, and use common sense, really.
Anne's got a question. This has been really useful. Can I access the past webinars anywhere? This is the first webinar we've done on practice standards, Anne. It will be going on the site in the next couple of days, and we will send out an email to let people know that where they can find that. And it obviously has been a free webinar, so you'll be able to view that and pass it on to friends if you think it's been useful. There are other webinars on the site, some of which you would have to pay for or be a member of. So if you've got anything particularly that you want to have a look at, then just send me an email at Anthony@thewebinarvet, and I can try and sort you out with that. We could probably go on all night, Pam, but I think probably what we should do is I'm aware that there are quite a lot of questions there, some which probably are a bit more, railing against the system, which I can understand can be a bit frustrating because there is a lot of work to do there. And, as a practice owner who went through practice standards at the tier 2 level, it was not an easy undertaking, but I did feel at the end of it there was a degree of satisfaction in knowing that a very highly rated colleague of mine, Harvey Locke, had been into the practice and said, do you know what, Anthony, on the whole, you're doing most stuff right. So
I agree.
I think we've got to be positive about it. If we're negative, we'll just start tearing our hair out. So,
and the practice standards inspectors are there to be helpful and to try and help the practices to get through. That's the ethos it should come from, and I think it does. So most of the practice standards, well, all the practice standards inspectors have been in practice, have had their own practices, and they've probably been inspected, and they're there to try and help. So
yeah, I mean, I had a previous inspection from somebody else, and I've always found them to be friendly. And of course, if as happened certainly at the first one that I did, there were things that I wasn't doing right, of course they then send you a list and give you the chance to bring it all up to date. So interesting. I think the final point is that you don't have to join the practice standards scheme.
No, absolutely not. You're right. It's a voluntary scheme. You do not have to join the practice standards scheme. That is not what it's saying in the new code. It's just saying you should practice equivalent to core standard. Yes. So therefore, it's sensible to have a look, if you're not in the practice standards scheme, what core standard is, and just ensure that your practice is practicing equivalent to core
yes.
standard. But no, the practice standards scheme is entirely a voluntary scheme. Nobody has to join it.
I had one of my members who's from the webinar vet, and he said, we're doing all of these things, but I don't want somebody coming around the practice having a nose around, as he put it, and telling me what's good and what isn't, and so on. So, that is also fine, but I think it is now a legal requirement that people are practicing at this core standard.
Well, everybody will get at least the VMD inspectors coming around and checking out the medicines. Absolutely, and but yeah, it's entirely voluntary. But most of the things in there are basic legal requirements, so it's just a security to know that you're complying with them.
I think just as a final one, we'll look at, I think, passing a lot of the questions over. I would ask you, if you really want to remain anonymous, do let us know. Otherwise, I will pass them over with names so that people can be replied to directly. So, do let us know what's going on there. Otherwise, I will whiz the questions over to the Royal College, and I'm not sure exactly how we're going to do it, but we will keep you informed on an email, whether it's in a blog from our site or the Royal College site, but we'll make sure that this information gets out, because I think there's a lot of interesting questions there. So hopefully everybody will benefit from the answers that come up.
Good, I'm looking forward to seeing them.
Yeah, and I've really appreciated all your answers, Pam. Fantastic webinar, really well answered with all the questions, and I think I'm positive about the practice standards scheme. I think there's a lot more positive about it than negative. So I'm sorry for those of you who perhaps aren't looking at it in such a positive way, but I hope everybody's enjoyed the webinar, and if nothing else, it keeps us on our toes. If we were talking about sort of straightforward things that everybody agrees with, it wouldn't be nearly as much fun.
You can never get vets to agree on everything anyway. So.
Well, one of my favourite comments from my German locum who used to work with me was, if two vets are in a room and they agree about something, one of them is not a vet. So with that, thanks everyone.
Thank you very much.
Good night.